I'm Dr. Michelle Plaster, and you're listening to Between Two White Coats, a weekly podcast where we dig into key issues surrounding health and wellness. I'm a family medicine doctor, and my co-host, Amber Foster, is a family medicine nurse practitioner.
In our combined 30 years in medicine, we've seen a lot. We are taking some of our biggest questions, obstacles, and patient-centered advice and wrapping it into a 20-minute weekly podcast. Make sure you hit subscribe so you don't miss an episode. If you have found this podcast helpful, give us a 5-star rating and review. This helps other people find our podcast. And make sure you share it with your friends. Thank you for your time. We look forward to serving you.
Thank you for joining us. We are so thrilled to have Jane Robinson with us again. We spoke in our last episode about anxiety, and Jane, I just think some of the stuff you told us was so amazing. So if you are a nervous person or a person who may struggle with anxiety and you did not hear our last episode, please go back and listen to it. There was some great information in there. And today we're going to go on to another really common situation, another common problem for people, depression. There's a lot of different approaches or diagnosis related to depression, seasonal affective disorder, where people have issues when they don't get enough sunlight and end up with depression through the winter. Or situational depression, where you're really in a time where this too shall pass, but sometimes it doesn't feel like it's going to pass, or the pain and sorrow during this too shall pass is too much. It's overwhelming. There are a lot of times where people don't know, is this depression? Is this just sadness? Is this a normal reaction to a lot of really bad stuff that's gone on in someone's life? So let's talk a little, Jane, about what is depression, what would be concerning if someone's listening to this and they're wondering, should I be concerned about this in myself or my loved one?
Okay. If you're feeling overwhelmed by it, or you're feeling apathy and you're not interested in the things in life that you've typically been interested in.
That is really huge. If I could just emphasize the apathy. Sometimes I'll say to people, being sad is one thing, but when you have a lot going on and you are in I don't care, I just can't care anymore. Yeah. That is when it's often an indication of something more that you may want to seek some assistance with.
That's right. Or you're sleeping consistently and during the day, and you don't want to get up, you don't want to go to work, you don't want to do things that you wanted to do in the past. Or obviously, if you're having suicidal thoughts, you would definitely want to seek help.
There's a lot of different presentations of depression, and you mentioned sleeping a lot. We have some screening tools that we use. The PHQ-2 tool is a simple 2-question. Have you lost interest in doing things that you would usually like to do? Are you feeling sad, lonely, depressed? And if you answer yes to one of those questions, that's a pretty decent tool to say it might be time to go talk to your primary care or seek out a counselor. Mm-hmm. The PHQ-9 is more a 9-question screening that digs into more of, have you lost your appetite or are you overeating? So there can be changes in food, whether you're under or overeating, or sleep, under or oversleeping, feeling a lack of worth, that it just doesn't matter if I'm here or not. I also, we typically think of depression as the female sitting in the corner, balled up in the fetal position, crying. And people will not relate to that, so they don't think they're depressed. I will frequently say for men, depression plus testosterone is often anger more than it is sadness. And so if you are explosive and cannot control your temper, if the person pulls out in front of you and you're going to run them off the road, if there is an inability to control emotions in a negative way, maybe it's sadness, maybe it's anger, but there's an overflowing of negative emotions. And I think, when do you get help? When is it a problem? When it's getting in your way.
Mm-hmm.
when it's keeping you from living your best life, when it's hurting your relationships with other people, your kids, we have people all the time in front of us say, I'm so short-tempered with my kids, I don't want to parent like this. Mm-hmm. And that's their point where they say, I want to be loving, I want to be patient, but I get home and I'm so on edge and I'm so upset about so much that that's not the person that I'm able to be. Mm-hmm. And that's when I think it's time to recognize that there are options and that there are treatments. What are some of the approaches that you take with patients for treating depression?
Well, I guess it depends too on the level. So if someone is severely depressed and, it looks like it could be something that could be from childhood or their past, you would need to use psychodynamic therapy and dig into those issues, the adverse childhood issues that may have happened to them, or, it may be it happened in their early adulthood. But honestly, with major depressive disorder, I would use psychodynamic therapy at first. Okay. Because I think many times you need to get to the root cause of what's going on. I would also advise them to see their primary care physician for possible medication in addition to the counseling. That's usually a good protocol.
And we talked a little in our first episode about when do you need medicines and when do you not need medicines. And we believe very strong that a diabetic cannot wish more insulin into their body, and a depressed person cannot wish more dopamine or serotonin or norepinephrine into their brain. And so if you are really thinking, I don't know why I feel this sad or why I feel this angry, I don't feel I have control over my emotions, it is very likely that you may not have control over your emotions. And that would be the time to really look at, would a medication that helps increase those chemicals, those happy chemicals, be appropriate?
Right.
And I think there's a number of times where we'll see people who have been working with a counselor, and the counselor has suggested that they come speak to us because they're doing the work, and they're digging in and they're learning things about how they can get better. But if they're not making the progress that the work would usually give them, then there may be more neurochemical things going on as well.
Right. That's exactly right. And, with depression, there's different presentations too. You may have someone presenting who is not able to get out of their bed every day. They're really, really struggling. They're hopeless. And that's a different presentation. I have also worked with people who are very highly functioning that are also very depressed. I mean, they are very depressed, but they are working 3 jobs.
Or they're a CEO of a company.
Yeah, exactly. So with those people, I would use psychodynamic, obviously, with the people that are highly functioning too, but then you get into the CBT again, because they're already up and able to move around. The people who are not able to move around, you're going to start trying to get them up and get them moving around, and maybe doing a little bit of exercise, walking to the mailbox and walking back to help get some brain chemicals moving. But if someone came to me in that condition, I would definitely refer to their primary care.
Yeah. And the CBT, reminding people, that's the cognitive behavioral therapy, where not only are you counseling people to look back and identify some of the areas that have caused them pain or trauma so that they can once and for all deal with and put that into a place that doesn't have to haunt them every day. But then also with the cognitive behavioral therapy, learning new tools, learning new behaviors, new ways to get control and keep control of your thought process so that you can dictate your day better.
That's right. And, many times when people come in severely depressed, there's shame. So you want to try to help that person reframe those thoughts, because children process emotionally. And so if a parent has been negligent or absent, they may feel like it's their fault or something was wrong with them, rather than being able to attribute that to where it belongs. So then they turn that anger inward, and then it turns into the shame, and those kinds of things. And so that cognitive behavioral therapy piece helps them reframe that and understand their parents may have had problems too. And it's not really that something was wrong with them.
Let's talk about the parents may have had problems too, the hereditary or trends in families of different mental illnesses, depression being bipolar, also being one, that has a genetic component to it. And so, I think a lot of people are in this bad place where they, without knowing it, were raised by a depressed parent. They suffer with the same neurochemical imbalance themselves and are in this really difficult and dark place because there's a hereditary component to this. And whether it is born or bred, there's also growing up in an environment where people were potentially abusive or not able to show love in a way that a child needed. And so that really can be difficult if you were raised in a home that suffered from depression and you yourself suffer from depression. That's a really hard place to be. But that does not mean that you're not able to heal from that. There's a lot of things that can still get you better, but don't ever find yourself in the place where you say, well, this has been my whole life, so I guess this is what I'm condemned to. It's
interesting because speaking of clients, I had a client that she said to me, her dad was depressed. She was depressed. She had siblings that were depressed. So she felt like there definitely was a hereditary component going on there. But she said, Jane, if I do these things that you're telling me, I'm going to get better, and I'm not sure I know how to function if I'm better. I said, you might actually function better.
Well, then putting herself too, a lot of times, like if she went back to that family where they're all depressed, but she's the one better, would she revert back, just to play the role in the family? Because then that misplaces, it misplaces her from what that norm looks like in that family.
That's right. Yeah.
And for so many people in that situation, that is their normal. Their entire life, they've only really ever been around people who function that way. And so, good for her to even seek out the help and realize that is not what she has to have.
And to admit, this is how I've functioned all of this time. If I do this and I'm better, how am I going to, I'm not going to know what to do.
Even going to look like.
Right.
Yes.
Yeah.
Let's talk for a moment about the difference between depression and grief.
Okay.
Grief is an area that you do a good amount of work in, and without question, I think that kind of loss is people's darkest times and most emotional and sad times. When do the absolute gut-wrenching pain of grief, when is that natural, and when does that require help or interventions?
Well, it's gut-wrenching no matter what, really. So I think if you feel hopeless because of that loss, or you feel seriously angry because of that loss, it may be time to get help. Because most people do struggle with denial and anger and depression, and bargaining, those 5 steps that Kubler-Ross discussed about grief. Most people do go through those, and sometimes you'll stay stuck in one and you don't go through them linear. You go maybe be in one and you'll jump back to this one. It jumps around. But when it's interfering with your life again, when you just don't feel like your life is right, you need to get help with the grief. And it is different because grief and depression are different in that grief has a precipitating event, right? Something has happened that has caused you to be incredibly sad. Sometimes depression, there might not be a precipitating event. Like you say, it could be hereditary. Grief, typically you can work through. Depression is a little more difficult. So you will see the variance in that. When you're sad, you might be sad that you didn't get to go on a trip somewhere, right? Which is completely different than if you feel such a significant loss of grief, or if you're just depressed and you can't get up every day. And sometimes grief can cause that as well. But typically with grief, you can get back to a sense of a purpose in life. You will process that loss and understand that connection at some point and be able to celebrate that connection that you have with that person or that pet. And you will be able to move on with a life purpose again. If you're not able to do that, you definitely need to get some help.
I have several patients, and I know we've all experienced grief and loss in different ways, but I've had patients who have had like situational depression because of grief. And so they were like, hey, I think I may need to be on something. And then we wean them off in 3 to 6 months. Not that they're over the death or whatever the event was, but they've realized, hey, okay, I've learned whatever this new normal, this new feeling, whatever it may be. And then we wean them off medication and they're still functional. So I think too, sometimes medication can be an option for even situational type depression that's associated with grief, but it's not true depression.
And I'm glad you say that, Amber, because I have so many patients who say, I don't want to take this the rest of my life. And I would say 90% of the medicines we give people for anything, we don't want them to take the rest of their life. There are some things that we can actually fix without doing a pill the rest of your life. But depression is very much for some people something that you may not need to take the medicine, or, counseling helps give you the skills, and it's not something that you feel like you have to do the rest of your life. There will be times where you might want to revisit things because life gets hard again, and then you do okay. So I'm really glad you bring up that there are short-term solutions to help you when you're really in the gut-wrenching, I have to function a certain way. I have to be able to do some things that I just don't feel like I can do right now. And there's a lot of different tools that we can use to help people.
And I think patients have even seen, oh, these were tools. I know that they're at my disposal if I need them again. And so that also gives them some sort of kind of like triumph feeling.
Yes,
like,
and takes away that despair that there's nothing that can help me.
And then patients realize like that it wasn't like true the major depressive disorder. It was situational depression associated with grief.
Right. Yeah.
And, we would be doing a disservice if we didn't touch on suicide, which of course is the thing that none of us want to touch on, because it's a really hard thing to talk about. And it's a scary place to be for people when they're having those thoughts of harming themselves. So we definitely want to make sure that we touch on and talk about suicide. Suicide is in the top 10 causes of death in our country. And I think people feel very alone when they suffer a loss from death by suicide, but they are not alone. It is a far too common thing. And we've talked about the stigma that goes with mental health so that people don't always reach out and get help before they get desperate. And the different statistics that go with suicide. 1.4 million adults attempt suicide annually. 60% of Americans have suffered loss due to suicide, and over 500,000 ER visits are due to self-harm or suicide attempts. That's a lot of people. So, I want people to know that this is not uncommon. And that there are a number of things that we can do to help people. And some suicides are even impulsive. So it may not be that people have been sitting and thinking about how they're going to do this and planning how they're going to kill themselves, that it may be more of an impulsive thing. So it's important to realize when you're in a place of anxiety or depression or OCD or any of these mental illnesses, don't wait until it gets worse, because you may not see coming that the permanent solution to the temporary problem, to the thing that we can offer help for if we can get to people before suicide occurs. What would you say to people who are concerned about a loved one who they fear may be depressed or suicidal?
I would say get them help immediately. Because immediately, because you can't know what they may do for sure. So if even if it means calling the suicide hotline and getting some counseling there, find a therapist, talk to the primary care doctor, but I mean immediately if you really are concerned about a loved one.
I think sometimes when you say suicide, people will think, well, I don't know that I have suicidal thoughts, but when I start pinning things down on patients, like, have you ever been driving and think about running off the road? Like those types of things, because they don't know where to place that. They think suicide is so far from them that they would, oh, I would never do this. But then when you start pushing, you're like, well, you're having these thoughts. And I don't think sometimes people realize how far they've gone down that road. And again, like I've had several patients say, well, there's been times when I've thought, well, if I could just go to sleep and not wake up, like it's not like they're trying to do something, major, what they would consider major, what we hear, what you see on movies and when the reports and things that you get. But even those types of things are like intrusive thoughts, like you were mentioning earlier, is that they will ruminate on those. And so that's part of the depression. The DSM-5 is those recurring thoughts of death, and so even that can be alarming to providers and to counselors, but maybe not to the patients themselves because they're there, and they live in this little circular guilt shame cycle of, well, why do I feel this way? I shouldn't feel this way, but I'm feeling this way, and how to break that cycle for patients.
And I am always struck when people say, when we ask, have you thought about hurting yourself or would you commit suicide? And they say, well, I think the world would be a better place without me, or I wish I would go to sleep and not wake up, but I would never do that to my family. And if you have to say anything and then follow it with a but, we're still concerned. It's still concerning and it's still reason to get help immediately.
Right.
Because there is an impulsive nature. And we spoke before about how with mental illness, the unfortunate organ that is sick is your decision maker. And so you can't decide that your heart beats or doesn't beat. The heart's going to do that without your decision. But when you're deciding, things comes from your brain and your brain is the sick organ, then you can today very honestly say in front of someone, but I would never do that. The world would be a better place without me, but I would never do that. And then your decision maker is sick and you have an impulsive act or something that you really believed you would never do. And so I would say to people, don't be reassured by but I would never do that. It still is reason to seek help immediately.
That's right. Anytime there is suicidal ideation, which is a little different from intention, of course, it's cause for concern.
Well,
at
I
any
think
point.
too, like mental health hospitals or places for those type, they don't see them as like an emergency room if you break your leg.
Right.
They see them as which the first thing that comes to my mind, because I have children, is like Batman Arkham Asylum, where it's like the absolute villains, crazy people live here, and I would never go there.
And we painted that picture even in childhood.
Well, and even exactly, the Batman movies are great for that, but also like even just Lifetime movies or things on television, like you don't want to go to the mental health hospital because they drug you and they do all these things, and that's not at all how it is.
That's not how it is.
But I think that's, as a society, we have done that very poor disservice because patients are so fearful to even go there. So then they're kind of where they feel stuck. We're only open a certain number of hours a day. You're only open a certain number of hours a day. And so then they feel helpless.
Right.
And they don't want to seek the emergency immediate treatment.
Yeah. So, call the suicide hotline.
Yes.
Really and truly, you don't have to see anybody. You can talk to someone and they will help talk people down.
Yes, and create a resource for whomever that is that they're talking to.
Right. It is so important to get help because, people don't really understand, I don't think, the seriousness of people who are considering suicide.
Yes.
But those people have reached a place of hopelessness and it needs to be addressed immediately. You're right. That's exactly right.
And so really with that, we would say if you have a concern about someone, get them to their doctor, get them to their counselor, psychiatrist, develop those therapeutic alliances. Our patients know we have an after hours number. You can call us at any time and speak to the doctor on call and we will get you whatever help you need at any day or time. That is true of most primary care offices, certainly of mental health resources as well. And then the suicide hotline is something that I think if you suffer from depression, or you have a friend or family member that suffers from depression, it's good to just have that information. And hopefully it's that information that you have and you never need, but you have it in case you do. There's been so much valuable information about depression, and it's such a common thing. We would really just want to encourage people to know that you are not alone if you are feeling down or apathetic. If you wake up and you're just like, I just don't care. I don't have the passion for life that I used to have. Maybe there's a reason, maybe there's no reason, but this is not an uncommon thing. But there are so many resources, and you don't have to feel that way. And so whatever it takes, reach out to those resources and make sure that you're asking for and seeking the help.
That's right.
We just can't thank you enough for joining us, Jane. The knowledge that you have and the passion that you have for helping people is incredible. Jane owns and runs Infinite Endeavors. And so you can find her out there in the World Wide Web. Sound like my mom saying that. We have just been blessed to be able to spend some time talking about mental health. This is something that Amber and I are both really passionate about because of all the things that we do to help people with their physical health every day. None of it really counts for much if you're not in a good mental space. And so getting your sugar down and your blood pressure controlled, but feeling like you just have no passion for life doesn't really do a whole lot. Thank you so much for joining us. Have a great day.
We like to finish each episode with a positive thought. So here's today's Tell Me Something Good. We have the ability to redirect our thoughts and select our focus. We can choose to think about positive things, or we can choose to allow our brain to be in the negative space. I encourage you to start to recognize when your brain is in a negative space and start replacing those negative thoughts with more positive thoughts. It will change the entire course of your day. Thank you for joining us today, and until next time, take care of yourself.